What we have seen at this first edition of ESMO Asia is additional follow-up and some additional characteristics of the CheckMate 057 study, that is the randomized controlled trial of Nivolumab versus docetaxel in relapsed non-squamous non-small cell lung cancer. And what we heard is that with longer follow-up, it's mature until 18 months now, is that there is a remaining survival benefit for Nivolumab compared to docetaxel, with a significant hazard ratio of 0.72, and it's also a clinically relevant difference. So it means that with longer follow-up, there is a persisting difference of better survival in favor of Nivolumab versus docetaxel in that trial. What we already knew, and that has not changed, is that the toxicity, of course, is far better for Nivolumab compared to docetaxel. We also heard something about patient-reported outcomes here, meaning lung cancer symptoms. And there, what was seen was that in the trial, in both arms, the symptoms of the patients more or less remained stable. They improved slightly, but they improved a little bit more, certainly on the long run with Nivolumab. So that as well is good news for the patients, because good symptom control is important in relapsed non-small cell lung cancer. So that was one part. The other part was looking at subgroups, and that is important because not all patients benefit from each treatment. We know this, by the way. The first thing is that patients with a less chaotic mutation pattern, meaning never smokers, or tumors that have an EGFR mutation, that are driven by an EGFR mutation, so that they are less complex in terms of mutation burden, they do less good with immunotherapy than the other tumors. And actually the response rate was a little bit higher for docetaxel than for Nivolumab in this group of patients. So probably when we focus on patients, the ones that are never smokers or the ones with a driver mutation are probably not the best candidates for immunotherapy, and luckily we have other options there, the targeted agents. And then, of course, the big issue about PD-L1 as a biomarker. I believe that PD-L1 is a biomarker. It's far from perfect. It needs further refinement. It needs further validation. But what you see in the data set of the CheckMate 057 study is that we mostly have information of below or above 10%. And what we see in one of the curves is that if your PDL staining is less than 10%, it means that your overall survival with docetaxel and Nivolumab is about the same. And that's important because it's a big piece of the study where Nivolumab does not add extra survival compared to docetaxel. And it will be important in the light of other things. One of these things is the financial cost of the treatment. If there's no overall survival benefit in those expressing less than 10% PD-L1, for some regions in the world that will be an issue, especially as we have other treatment options for these patients, such as docetaxel combined to nintedanib, docetaxel combined to ramucirumab. There are other options that also may be valid options for that patient. So I think we certainly need to learn more about PD-L1 in relation to Nivolumab in patients with non-squamous non-small cell lung cancer.